If you're over 60 and taking a statin for your cholesterol, there's a conversation happening in cardiology right now that your doctor may not have had with you yet. It starts with a warning that the FDA quietly required to be added to every statin label over a decade ago. A warning about memory loss, confusion, and cognitive changes. Most patients never see it. Most doctors never mention it. But the research behind it has only grown more complicated since then. And if you're wondering whether the drug you've been taking for years is actually doing more good than harm at your age, that question deserves a real, evidence-based answer. I'm Dr. Ethan Reid, and this channel is built for one purpose: to bring you the latest research in plain language, specifically for those of us over 60.
If you haven't subscribed yet, please do. We release new, evidence-based content every week. And the information we're discussing today is something I genuinely believe every senior on a statin should hear. Now, let's get into it. Statins are the most prescribed class of medication in the United States. We're talking about atorvastatin, simvastatin, rosuvastatin, lovastatin, drugs that over 40 million Americans take every single day. For decades, the standard approach was straightforward. Elevated cholesterol reading, write the prescription, refill it indefinitely. And for certain patients, that approach is absolutely supported by strong evidence. But the science has grown considerably more nuanced, particularly when it comes to people over 60, and especially when it comes to what these drugs do to the organ that needs cholesterol most, your brain. Let's start with the FDA warning, because this is where most people's eyes go wide. In 2012, the FDA required all statin manufacturers to update their product labels with a warning about cognitive side effects. The updated labels specifically state that patients have reported memory loss, forgetfulness, and confusion associated with statin use. Crucially, in most reported cases, these symptoms reversed when the statin was discontinued. That last part is important. These were not symptoms of aging, they were not inevitable, they were drug-related, and they went away when the drug was removed. Now pause here and think about that for a moment. If you've been on a statin for years and you've noticed that your memory feels less sharp, that you can't retrieve names the way you used to, that conversations feel harder to track, and your doctor attributed it all to getting older, that FDA warning says your doctor may have missed something worth investigating, comment below right now. Are you currently taking a statin? And have you noticed any memory or cognitive changes in the years since you started? I want to hear from you because the pattern of what people share in these comments tells us something important. To understand why this happens, you need to understand something about your brain that most people don't realize. Your brain is roughly 60% fat, and a significant portion of that fat is cholesterol. But here's the critical detail. The brain makes its own cholesterol locally. Cholesterol from your bloodstream cannot easily cross what's called the blood-brain barrier, a protective system that filters what gets into your brain. So your brain's cholesterol supply is essentially self-contained, and it's essential for building myelin, the protective sheath around nerve fibers. Think of myelin as the rubber insulation around an electrical wire. Without it, signals slow down, short circuit, and lose clarity. Here's where statin type becomes a critical distinction that most patients are never told about. Not all statins are the same when it comes to brain exposure. Statins fall into two categories. Lipophilic statins, fat-soluble, can cross the blood-brain barrier by passively diffusing through fatty tissue. Atorvastatin and simvastatin are the most commonly prescribed examples. Hydrophilic statins, water-soluble, rely on active transport mechanisms and tend to stay concentrated in the liver rather than spreading into brain tissue. Rosuvastatin and pravastatin fall into this category. Multiple published reviews, including a systematic analysis cited in Frontiers in Aging Neuroscience, have noted that lipophilic statins are associated with higher rates of cognitive complaints than their hydrophilic counterparts, and that hydrophilic statins appear to have more protective effects on dementia risk. A meta-analysis published in 2020 found that hydrophilic statins were associated with a 28% reduction in all-cause dementia risk compared to 16% for lipophilic statins.
That's a meaningful difference, and it's one that patients and their doctors can act on. But here's what I really need you to understand, and this may be the single most important point in this entire conversation. The debate around statins for people over 60 is not just about side effects. It's about whether the drugs provide meaningful benefit in the first place for a large segment of the people currently taking them. And the answer depends entirely on one question. Are you taking a statin because you've already had a heart attack or stroke, or are you taking it simply to lower a number on a blood test? Medicine calls these two situations by specific names. Secondary prevention means you've already had a cardiovascular event, a heart attack, a stroke, a stent procedure, and you're taking the statin to prevent another one. The evidence for statins in secondary prevention is strong across all age groups. If this is your situation, statins genuinely save lives, and any conversation about stopping should be extremely careful. But primary prevention means you've never had a cardiac event. You have elevated cholesterol, maybe some other risk factors, and your doctor put you on a statin to lower your future risk. And this is where the evidence for people over 75 becomes genuinely uncertain. In 2017, a secondary analysis of the landmark ALLHAT-LLT trial was published in JAMA Internal Medicine. The researchers examined outcomes in over 2,800 adults aged 65 and older with hypertension and elevated cholesterol, but no prior cardiovascular disease. These were people taking statins purely for primary prevention. The findings were striking. Statin therapy in this group produced no significant benefit in all-cause mortality, coronary heart disease, or stroke events. In fact, there was a non-significant trend towards slightly higher mortality in the statin group among those 75 and older. The authors concluded that statins may be producing effects in older adults that offset any cardiovascular benefit. This is one study, and it has limitations. But it mirrors a broader pattern in the evidence base that has led multiple guideline bodies to call for individualized, shared decision-making rather than automatic statin use in seniors without established heart disease. The European Society of Cardiology's guidelines go further, cautioning against what they describe as uncritical initiation of statin therapy in those over 60, even in patients with high estimated cardiovascular risk. The U.S. Preventive Services Task Force has acknowledged that the evidence for statins in primary prevention for adults over 75 is simply insufficient to make a clear recommendation either way. This isn't fringe medicine. This is the mainstream scientific community acknowledging genuine uncertainty. Let me tell you about Harold, a 73-year-old retired engineer whose wife noticed he was losing words mid-sentence. He'd be explaining something to his grandchildren, stop completely, and the word he'd been reaching for would simply not come. His doctor said it was normal aging, but Harold had been on atorvastatin 40 milligrams for 11 years for primary prevention, based solely on a high total cholesterol reading. No prior heart attack, no prior stroke. After researching the lipophilic, hydrophilic distinction, his new cardiologist switched him to rosuvastatin 10 milligrams. Within 3 months, Harold told his doctor the fog had noticeably lifted. His thinking felt faster. He was finishing his sentences. Was it the statin switch? It can't be proven definitively, but the timing was consistent with what the research predicts. There's another side effect issue that deserves direct attention, and it's one that becomes significantly more dangerous with age. Statin-associated muscle symptoms, ranging from mild aches to a serious condition called myopathy, affect somewhere between 5 and 20% of patients, with rates increasing substantially in adults over 65. The most severe form, called rhabdomyolysis, involves actual muscle fiber breakdown that releases proteins into the bloodstream and can damage the kidneys. This is rare, but it becomes more likely at higher doses in older patients with naturally declining kidney function and when statins are combined with certain common medications, including antibiotics like clarithromycin, antifungals, and some heart rhythm drugs. If you're over 65 and taking a high-dose statin, Your doctor should be reviewing your full medication list regularly with this interaction risk in mind. Statins also consistently reduce blood levels of coenzyme Q10, CoQ10, a compound involved in how your cells produce energy. This happens because statins block the same biochemical pathway that produces both cholesterol and CoQ10. The JASCC published a systematic review confirming that statins reliably lower plasma CoQ10 concentrations. What remains debated is whether supplementing CoQ10 reliably relieves statin-related symptoms. The studies are genuinely mixed on that question. But given the low risk of CoQ10 supplementation itself, many physicians do recommend it as a precautionary measure, particularly in older patients. This is a conversation worth having with your doctor based on your individual situation. What I want you to take away from all of this is not fear of your medication. Fear is not useful. And abrupt changes to cardiac medications can carry their own risks. What I want you to take away is clarity about the questions worth asking. Here's exactly what that looks like in practice. Step 1. Find out whether your statin is being used for primary prevention or secondary prevention. Ask your doctor directly, have I actually had a heart attack, stroke, or confirmed cardiovascular event, or is this statin purely to manage my cholesterol numbers? The answer to that question determines the entire strength of the evidence behind your prescription. Step 2. Identify which statin you're taking and whether it's lipophilic or hydrophilic. Atorvastatin and simvastatin are lipophilic. Rosuvastatin and pravastatin are hydrophilic. If you're on a lipophilic statin and you've noticed cognitive changes, ask your doctor whether a switch to a hydrophilic alternative at an equivalent dose makes sense for you. Step 3. If you're staying on a statin, ask about CoQ10. A commonly recommended starting dose is 100 milligrams daily of the ubiquinol form. Ubiquinol, not ubiquinone, absorbs more effectively in people over 50. Take it with a meal containing some fat, since it's fat-soluble. Ubiquinol CoQ10 is available at most major pharmacies, including CVS and Walgreens, and online. Step 4. Keep a brief symptom record over 6 to 8 weeks, noting energy levels, mental clarity, and any muscle aches. This gives your doctor objective information to work with rather than general impressions. And a critical caution, do not stop your statin abruptly without your doctor's involvement. If you have cardiovascular disease, there are real risks to sudden discontinuation. This is about informed, shared decision-making, not unilateral action. Let me tell you about Eleanor, a 69-year-old former librarian who had been on simvastatin 20 milligrams for 7 years. She came to her physician with what she described as thinking through cotton wool. Everything felt slower, harder to access. She had no prior cardiac events. Her statin had been prescribed when her LDL came back at 148. Her doctor reviewed the 2017 ALLHAT data, discussed her individual risk profile, and together they made the decision to taper and eventually discontinue. 8 weeks later, Eleanor said her mind felt clearer than it had in years. She added structured Mediterranean-style eating and regular walking. Her follow-up lipid panel a year later showed her LDL had risen modestly to 161, but her overall cardiovascular risk score had actually improved, driven by weight loss and blood pressure changes. Eleanor's outcome doesn't mean every patient should stop their statin. It means the decision deserves to be made with full information, not on autopilot. The bigger message here is one about precision in medicine. A drug prescribed at 55 may not be right for you at 72. Your cardiovascular history, your cognitive status, your other medications, your kidney function, and your own goals for quality of life, these things change. And the research says clearly that treatment decisions should change with them. So let me leave you with the essentials. If you're over 60 and on a statin, find out whether it's for primary or secondary prevention. Identify whether it's lipophilic or hydrophilic. Have a real conversation with your doctor about your cognitive symptoms if you've had them. Discuss CoQ10 supplementation if you're staying on the medication, and bring this research to that conversation. You are entitled to evidence-based care, not just a refilled prescription. Drop a comment below. Tell me whether you're on a statin, which one, and whether any of this raised questions you haven't asked yet. And if this helped you, please subscribe to this channel. Next week, I'm covering the one blood test most doctors still don't routinely order that predicts heart attack risk far more accurately than your standard LDL cholesterol number. The result might genuinely change what you ask your doctor for at your next appointment. I'm Dr. Reid. Stay curious about your health, ask better questions, and I'll see you next week.